This should be the real title of the talk. In the past 10 years, I've seen real headway in the consistent use of standardized screening tools. As far as I'm concerned, the candle has definitely been lit. I don't think it's as arbitrary the way we approach developmental screening as Chris implied. I think there has definitely been real headway, and the headway has occurred in part because providers are reimbursing now for standardized tools. That really has had an effect. Developmental screening became important with the passage of the Individuals with Disabilities Education Improvement Act of 1990. This federal statute recognized the importance of early intervention in improving developmental outcome for high-risk and developmentally delayed infants and toddlers under 3 years of age. The Act mandated statewide systems to address these needs and allowed the states to set up their own eligibility requirements. In California, these services are provided through the regional center system. The initial goal was to provide services to 2%, which is currently being exceeded. An obvious initial question is how large is the actual population that may qualify for these services? To determine how many children were not receiving services, data from the Early Childhood Longitudinal Survey birth cohort was reviewed. This longitudinal study represented a sample of all the children born in 2001. So there was a statistical sample. The majority of the sample children were evaluated at both 9 months and 24 months of age. A limited research version of the Bayley infant developmental scales was utilized, and they utilized statistical criteria for eligibility of 1 standard deviation below the mean on the 2 scales, or 1.5 standard deviations on one or the other scale as qualifying criteria. Some states were using that criteria. California uses an age-based criteria, and the age-based criteria is 50% delay in 1 of 5 domains, or a 33% delay in 2 or more domains. Although, as Chris mentioned, and I'll mention later, under 2 years of age, we have more liberal referral criteria. So this study, the rates of children who should be eligible are very high, much higher than I expected. I'm really glad I had a chance to re-review this topic. And it's obvious that currently only a small percent of potentially eligible children are receiving services. This study, on this study and similar studies in the past, it's apparent that poverty is a significant risk factor for a child to have a developmental delay. It's also apparent that if you're white, you're more likely to receive services than if you're black. Hispanic rates of referral were actually only a little bit behind the white population. If you include low birth weight, 13 to 15% of infants and toddlers should be eligible by these criteria. And again, even though California uses different criteria, you would expect similar rates of eligibility. I thought this number was very large, much more than I expected. So I looked at the situation with the older children. The CDC states that 17% of children under 18 years of age have a developmental or behavioral disability. The numbers in this slide are from California, and they represent recent rates of identification of school-aged children with special education services. I've included this information just to give an idea of the percentage of older children who receive special services. The bottom line is that the percentage of eligible children for special services in both the toddler years and school age years is in the teens. It isn't 1 or 2%. It should be apparent that we're missing a lot of children who qualify for developmental services. The purpose of screening is to identify those with unsuspected abnormalities. Screening is not useful in children who have already been identified as delayed. I just mentioned this because I'm impressed how often I see a child who already is in the system receiving developmental services have a screening tool administered, and what do you know, they fail again. Before discussing the specifics of screening, it's worth mentioning the programs available in California. Early Start is the California implementation of the Individual with Disability Education Act. It provides services to eligible children. California recently implemented the prevention program for case management of high-risk infants and toddlers who did not fulfill the Early Start criteria, but did fulfill another set of criteria. Here's my suggested approach to developmental screening. History and physical will identify some children who should be immediately referred to appropriate agencies. I think this handout should be in your materials. The importance of risk factors can be seen in this list, which is a compilation of the state's criteria for at least case monitoring services. Basically, have a low threshold to refer if there are more than 2 of these risk factors or if you have a single risk factor of high severity. Note that these risk factors involve historic items like birth history, prenatal history, and family history, such as a parent with a developmental disability, in addition to abnormalities that may be found on exams, such as physical findings of dysmorphism suggestive of genetic disorders, or the results of teratogens such as alcohol. Okay, the first subliminal message about screening. The concept of screening is straightforward. Screening tests are administered to whole populations, not just those you suspect of having a problem. The milder problems are more common and the most amenable to therapy. Notice the last statement, which really hurts, and which Dr. Landon already alluded to. Why can't we just use clinical judgment? Studies have looked at this and suggest highly inadequate sensitivity. First of all, we're all aware of the large variation of normal. This often leads to expectant observation when milestones are just a little bit late. You know, the doctor's saying, don't worry, he's a boy, he'll do better, just give him a little bit more time, they're slower. Secondly, as we run through our days, we tend to notice and recognize the more obvious problems. These are the least prevalent. Third, the milder deviations are more subtle and therefore more likely to be missed. These milder deviations are much more common than the severe deviations. The milder deviations are also more amenable to therapeutic interventions, so you would really like to identify them early. Finally, as practitioners, we want the best for our patients and their families. Like parents, we are susceptible to overlooking minor problems and assuming that things will correct over time. We have a denial just as good as our parents do. Unfortunately, things don't always fix themselves. This leads to the obvious screening test corollary. If you see a problem, it is a problem. Refer, don't bother screening. There are many challenges to screening young children. I love item 3. In my office, a nice, smiley, older man comes in, attempts to play with the child, then a nice smiling lady walks in, sticks needles in them. By 15 months of age, 12 to 15 months of age, the kid has figured it out. They're not going to do any kind of developmental performance for you. They're going to cling to their parents' lap. The last item is also important. New developmental achievements are demonstrated inconsistently and then usually only in familiar environments. That's why it's often difficult in an examining situation to elicit skills that the parents just swear the child displays.